Hi, welcome to the 2017 Geriatric Lecture Series. This is being sponsored by the Iowa Geriatric Education Center here at the University of Iowa. Our 2017 series is going to be focusing on dementia. So all of the presentations this year will be discussing some aspect of dementia. And today we're going to talk about advanced directives in the context of dementia. My name's Mercedes Byrne-Klug. I'm an associate professor with the School of Social Work, and I also direct the Aging Studies program here at the University of Iowa. Please don't hesitate to contact me if you would like additional information or if you're interested in learning about how you can earn a certificate in aging studies. I have nothing to disclose. Let's start out with the mission of the Iowa Geriatric Education Center. Its mission is to help prepare Iowa's health practitioners to care for our growing population of elders. And so this presentation and all the presentations in this series is focused on helping practitioners better understand some of the issues that are occurring in caring for our older population, and also to bring you up to date on some of the literature and some of the current thinking. And so what I've done as part of my presentation today is actually included the citations to some of the key readings so that if you're interested in finding these yourself, you can look them up. And I'll also tell you a little bit about some of the other information that's part of these publications that I just don't have time to talk about today. So the objectives for today, first of all, we're going to talk a little bit about dementia. But as I mentioned, dementia will be discussed in all the lectures this year, so I'm just going to touch on it. I'm going to talk a little bit about stages of Alzheimer's disease, one type of dementia. And then we'll talk about advanced directives and distinguish the concept of advanced directives from advanced care planning. And then I'm also going to throw in a little bit about the POLST paradigm, which is related to advanced care planning. All of that background from part 1 and part 2 is to get us to part 3, which is actually the heart of what I want to talk about today, and that's considering advanced directives in the context of as the person is declining from dementia. So that will be how we end our presentation today. This is from the NIA, and it's a document that talks about dementia in general, and it might be something that you want to use yourself to learn, to get updates on what's happening with dementia. The NIA presents a lot of reports on an annual basis or biennial basis that kind of is the state of the science, or also working with material that you can share with patients and their family members. So some of the NIA material is geared toward professionals, other of the material is geared toward families, and so if you're ever looking for handouts for your office or for ideas on how to talk about some of these concepts with lay people, I invite you to go and look at the NIA website, the National Institute on Aging website, and you'll probably find some very useful and helpful examples there. So when we're talking about dementia, we're talking about the loss of cognitive functioning. And dementia is a collection of symptoms. So that's what we're really talking about. And this loss of cognitive functioning is going to result in the loss of a person's ability to think, to remember, to use their reasoning capabilities, and then there's also going to be changes in behaviors. And when these changes accumulate, there'll be changes in a person's daily life and their activities and basically what their life is like. So dementia is a serious condition, and it's something that anybody who's working with older adults needs to be familiar with. Now, there are many types of dementia. There's not just one kind of dementia, and the different types of dementia will take different courses. So how the condition unfolds is going to vary by the type of dementia and on other issues as well. Some types of dementia are reversible, And so that's why it's so important to screen for dementia as part of an annual, and if there are some indications that the patient may be showing signs of dementia, we need to try to figure out what is the source of that, because some types of dementia are reversible and we want to get that treatment to the person as soon as we can. Many types of dementia are not reversible, or at least they're not reversible now, and many are progressive, which means they're going to continue to worsen. The symptoms of the dementia are going to become exacerbated, and that will eventually lead in declines in function. That often results in it being very difficult for people to live alone safely. So we do see many people who, if they live toward the end of dementia, are moved to nursing homes and other settings that have supervision. Of all the kinds of dementia, the most common is Alzheimer's disease, and that's probably the kind of dementia that most of the people that you're working with, most of your patients or clients have heard about. But it's important to remember that Alzheimer's is just one type of dementia, and that's why people shouldn't assume they have Alzheimer's. If they're having signs of dementia, we want them to get into a clinician, and we want them to be screened so that we can figure out if they have a type of dementia that's reversible. And even if their dementia is not reversible, it's good to get in with a clinician and have the diagnosis so that other planning can take place. Very emotional time. It's a crisis in people's lives and the crisis in the life of the family. But it's also good to have some information to help make some sense of what the person is experiencing, and then also try to smooth the path to the extent possible for the future. It's important to remember that it's not uncommon for people to have more than one kind of dementia at the same time. And that's why it can also be confusing to try to parse out, what is the source of these symptoms, because it might not fit exactly into just one symptom. If you're still learning about different kinds of dementia, I would highly suggest the citation on the screen here, because it goes through all sorts of different kinds of dementia, and then by reading that you get a sense of how different this collection of symptoms can portray itself in individuals. All right, now we're going to talk a little bit about Alzheimer's disease as the most common kind of dementia, and the FAST. So the FAST is a tool that was developed to lay out where it is on the continuum that a person with Alzheimer's may be. And by that I mean it's a way to look at function, an individual's function, so this is a tool that you use at the individual level, and try to identify where in the process of Alzheimer's, where in the unfolding of this disease, this individual might be. It's useful to do that so that you can track changes over time. And the whole idea of the FAST is also useful for people who are working with people with Alzheimer's, because then as we're preparing social workers and nurses and others for working with people with Alzheimer's, they have a sense of what the range of functionality might be when we're working with people. So I'm just going to kind of take you through this. I know it's very little, but I wanted just to point out what's highlighted. So it goes through, this is the first of 3 slides that look at the FAST. And it talks about these different stages and then, or levels, and then what it means. So that just by going through this, if you're not familiar with Alzheimer's dementia, this is a really good way to quickly come up to speed on the variation of functional decline, and often in the order of it. So first of all, the first stage is no objective or subjective functional decline, and that's what we would also consider normal. a normal adult or a normal older adult. And so on the column farthest to the right, you see the clinical diagnosis. And so if somebody is considered to have a fast stage of 1 or 2, they're not showing any signs of dementia. They're not showing any signs of Alzheimer's. If we go down to number 3, we're seeing some deficits that are noted in, especially if the patient is in a demanding occupation, or some of these deficits might be first noticed in social settings. They might be losing directions, they might be forgetting how to get home, things like that. And so that's where people are beginning to recognize that some of their function might be changing. On the fast stage 4, that's considered mild Alzheimer's disease, and it's deficits in performance of complex daily living tasks. And you can read the examples there: balancing a checkbook, having a hard time negotiating businesses, organizations. Those are often called IADLs, instrumental activities of daily living. That's a whole different kind of a system, but this is what we would be considering mild mild Alzheimer's disease. Now, this might be then when people come in and get diagnosed. They're probably going to come in at a fast stage 3 or a fast stage 4. And that's particularly important for our discussion today because we're talking about advanced directives. And these advanced directives, if they are going to be made by somebody who's been diagnosed with Alzheimer's or another dementia that's progressive, that's probably going to be happening while the person is in stage 3 or 4, because as the disease progresses, they're going to lose the ability to discern what it is that they might want. And so that's why it's so important to get people in and get them diagnosed early, and then start doing some planning. By the time we get to the 5th stage, people are having a hard time figuring out how to get dressed properly and to live in the community by themselves. They're going to need a lot of support, a lot of probing, and it might not be possible for them to live in the community alone. They might need to be under much more supervision. This slide shows stages 6 to 7, and then there are subsets. We're not going to go through all of them. I'm going to go a little bit more quickly, but I just wanted to call your attention that the first 5 items on this slide are considered moderately severe Alzheimer's disease, and then the last one is severe Alzheimer's. And so that's kind of the big picture of where we're going with this. 6A, this is the stage at which a person will be requiring physical assistance in actually getting dressed. And it gives some other ideas. 6B, bathing safely and properly, people are going to need assistance. So you can see that as the fast stages get higher, people become more dependent on somebody else. Their ability to function independently dramatically declines. How long does this take? It depends on the dementia, depends on the person. Somebody could go through these stages over the course of a few years. Other people, it might take a decade or a decade and a half. It really depends. And we'll be getting into that a little bit more later on in this lecture series, when you'll be hearing from physicians and people who are trained in actually understanding how these different types of dementia unfold. 6C, people need help using the bathroom, which is at the point at which some family members have a difficult time keeping the person at home. That just seems to be a cutoff in the literature, that as long as a person is continent, we try to keep them at home, but once there are problems with using the toilet, it just can be too much. It might exceed what the family is able to do. 6D, urinary incontinence. 6E, fecal incontinence. By the time we get to 7A, the person is considered to have severe Alzheimer's disease, severe dementia, And during the average day, they might be just saying 6 words, about 6 words, give or take. But you can get a sense of the decline in the functional ability. All right, so now we're looking at the last slide that talks about the FAST. These are all stages that are considered severe Alzheimer's disease. They're all in the sevens, but they're subsections. So 7B, the very limited intelligible vocabulary. 7C, ambulatory lost. D, the ability to sit up by yourself. E, the ability to smile. And then the ability to hold the head up. Now, not everybody with Alzheimer's disease lives long enough to have all of this happen to them. And some people are okay with dying before they get to stage 7F. And that's also relevant to today's conversation, because as people learn more about the normal progression of the type of dementia that they have, they may or may not be interested in having medical interventions aimed at keeping them alive as long as possible. Some people are going to want to. They feel very strongly about that. Other people don't. And so as a clinician, you're going to be having these kind of conversations with people, and you'll be finding out just how much variety there is there. The citation is listed on the bottom of this. It's an older citation, I know, 1986, but this is a very commonly used tool. And if you're going to be working with people with Alzheimer's, it's a tool that you really should be familiar with. Whether or not you use it in your organization or your agency, that's up to your own policies. But it is a good way to help describe what people with Alzheimer's go through, and eventually what happens as the disease progresses. All right, so with Alzheimer's, we talked about the stages. In the early stages, people are able to communicate about their preferences for future medical care. And so even somebody with mild cognitive impairment may still be able to communicate that. But we want to get these preferences discussed as early in the process as possible, where people have their faculties so that they can discern what it is that they think they might want later. And that's the whole purpose of the advanced directive, right, where somebody indicates what it is that they might want later on. Because we know that in the late stages of Alzheimer's and other types of progressive dementias, that the ability to meaningfully communicate decisions related to medical interventions will be lost. So in order for an adult to agree to an intervention or agree to not have an intervention, we want them to be able to discern. That's the whole idea of informed consent, that a person can understand what that treatment is and what the likely benefit is and what the likely costs are. And then they may, knowing this information, they make a decision about whether or not they want that treatment. By the time we get to the late stages of progressive dementia, absolutely the ability to discern, the ability to weigh those pros and cons for a medical intervention, they're just not there. And so it's too late to fill out an advanced directive at that point. So let's talk a little bit now about making plans about future care while people are cognitively able. This is another classic article published in 2006. It's a position statement by the American Association for Geriatric Psychiatry, published in the American Journal of Geriatric Psychiatry, where it's kind of like a consensus statement looking at principles of care that are considered best practice for working with people with dementia coming from Alzheimer's, but many of these principles work for dementia in general because many kinds of progressive dementias share a lot with Alzheimer's disease. So this is a good statement for you to be familiar with, and then depending on your profession, part of this manuscript may be of interest to you and part of it may not. But what's of interest to me for today is under the area of critical interventions, and that's part of this manuscript. Item number 4 is advanced care planning and advanced directives. So remember, this is a position statement from geriatric psychiatry about principles of care for people with dementia, and here they're saying that a principle of care is advanced care planning and advanced directives. And the reason that they're doing this, they're saying it's necessary to extend the patient's autonomous decision making. So that's the idea behind the advanced directive. And the last part of this slide says, during the later stages, decisions about life-extending measures like gastronomy and intravenous hydration should respect advanced directives by patients and incorporate participation from surrogate decision makers. And again, if you want to read the whole manuscript, they have a lot of other recommendations as well, but this is the one that's relevant to today. So I've been kind of dropping the term advanced directive. Now I want to actually define it and talk about it. An advanced directive is a tool to communicate future healthcare wishes. Adults of any age, as long as they're 18, can have an advanced directive, and I'm going to say should have an advanced directive, because an advanced directive is a way for us to communicate what our future healthcare wishes are in the event that we lose the ability to communicate. And that can happen to anybody at any time. A bad car accident, a sudden condition, you know, things do happen. They don't happen often. It's not really frequent in the big scheme of things, but it can happen to anybody. And so in the event that a serious injury or illness occurs, and I lose the ability to communicate my wishes, somebody's going to have to make medical decisions on my behalf, and an advanced directive is a way for me to give some directive about what it is I might want. Now, there are different kinds of advanced directives. The one that most health professionals and most consumer advocacy groups say is the most important. If you're only going to have one, which one should it be? It would be the durable power of attorney for healthcare, DPOA. The durable power of attorney for healthcare, states call it different things, but that's a common term. And it's an instrument that a person uses to appoint somebody else as that decision maker in the event that they can't speak. So for my durable power of attorney for healthcare, I would be deciding who it is that I say you can speak on my behalf in the event that I can't speak, and I'm putting it in writing. Now, hopefully you've talked to the person ahead of time and that person wants that role, and then you've also gone into a discussion about what it is you want. We're going to get into that a little bit later. But so the durable power of attorney for healthcare is important, and it also communicates to the medical team who is the person. If there's disagreement among the family or among the children or siblings, who is the person that the patient said speaks for me? We also have to recognize that many people are confused about durable power of attorney because there's another instrument called a power of attorney, and that has to do with financial things. That's different. So a durable power of attorney, the durable part means this still works when somebody loses the ability to communicate. And so the durable part is very important. A living will is another option for an advanced directive. It is invoked when a person has about 6 months or less to live. So it's considered when a person is in the terminal phase of an illness, and then people can indicate what kind of care they want. One of the drawbacks of a living will, though, is that you can't always get people to agree when it is that a person is in the terminal phase. So that has proven to be less useful. A healthcare directive, another kind of advance directive, and this, it can take many different forms, but it is where the person or the potential patient indicates which kinds of interventions they'd like to have or which kinds they'd like to not have. So if somebody wants to make sure that they do get a feeding tube, or they want to make sure that they don't get a feeding tube under certain circumstances, then a healthcare directive can be a useful tool for that. A drawback is that it's really hard to know what it is you might want when you haven't been diagnosed with a condition yet, and you're really not sure when this might come into effect, this being the healthcare directive. So generally speaking, for otherwise healthy people, we definitely recommend the durable power of attorney for healthcare, but a healthcare directive may or may not be that useful. Once a person has a condition and and the course of that condition is pretty well understood, it might be a little bit more useful. There are different kinds of discussion guides that are available for people to talk about their advance directive wishes. I've listed a couple there, and you can just Google them and find them on the website. This is a picture of my mother in Hy-Vee. My sister and I met with my mother in Hy-Vee to go. We all decided to complete the 5 wishes approach. This was, I don't know, maybe 10 years ago. And my mom's holding up the one in Spanish because I wanted to remind practitioners that with the increasing population, the Spanish-speaking population in Iowa and in many parts of the Midwest, that many of these tools are available in multiple languages. And so the 5 wishes approach, you sit down, you can kind of go through this booklet and it guides a conversation. And we need to remember that the purpose is to support self-determination and autonomy, the purpose of these advance directives, and also to help the person who's going to be making those decisions, help that person know what it is that they should be advocating for, and hopefully why, and that gets at the values. I need to say that many advance directives don't get at the values, and so that can be a drawback too. Advance directives is different from advanced care planning. So think of advanced care planning as the umbrella, and it often does include an advance directive, but it's not the same. So advanced care planning is a process. It's a process that takes place over time, and it includes discussions about the person's situation currently, discussions about what could happen, what typically happens for people with this diagnosis or these sets of conditions, and then the kinds of treatment decisions that typically come up for people with that diagnosis. And so it's a process because it should happen over time, because especially people who are not trained in medicine or nursing or don't have a healthcare background, all this information is a lot to take in, and people might change their minds. They might change their minds as they get more familiar with what it's like to try some of these treatments. They might change their mind as they get more accustomed to having the condition. All sorts of things can happen. And so we want to keep the door open to continue having these conversations. And ideally, you're going to include in the conversation the surrogate decision maker, right? So if this person is going to be speaking on behalf of the patient, let's all get on the same page by having these joint conversations. And now Medicare is paying for some advanced care planning. So we're going to now I want to pull this together, advanced care planning versus advanced directives. Both of them talk about medical preferences. The advanced care planning is a process. It happens over time. It includes discussions, and it absolutely should include discussions related to the patient's values. What do they value in their life? So that the person, the surrogate decision maker, will have a much better understanding of the values that are driving the patient's wishes. That doesn't always happen when someone completes an advanced directive. In fact, it generally doesn't happen. But with advanced care planning, it's fundamental. The advanced care planning process includes or can include the completion of an advanced directive. And then, as I mentioned, it's ongoing. With an advanced directive, sometimes that's just a one-shot deal. It's an event. People sit down, sometimes with their attorney, sometimes with their spouse, sometimes with their licensed independent practitioner, and they fill out a document and they consider it done. And so even just the way I've described that, you can see that it's going to be much more useful to the surrogate decision maker to have that whole discussion, the whole conversation, the process of advanced care planning. And in fact, the literature does show that advanced care planning is much more effective. I want to say just a few words about POLST, because POLST has been considered part of an advanced care planning process. POLST stands for Physician Orders for Life-Sustaining Treatment. It's called something different in different states. Here in Iowa, we call it IPOST, but the paradigm that started this whole thing is called the POLST paradigm, and it started in Oregon over 20 years ago, and now many states have adopted Oregon's approach to POLST, or are in the process of adopting it. POLST is a physician's order. It's a physician's order. It is not an advanced directive made by a person. It's a physician's order, or in Iowa, the order of a licensed independent practitioner, that directs what is to happen under certain conditions. And so POLST is not for all adults. We mentioned advanced directives are appropriate for any adult. A POLST is not appropriate for any adult. POLSTs are intended for people who are really at the end of their life. They maybe have a year or two left. They're kind of in that category, you think. They are quite frail, or they're at high risk of dying, even if it's not clear when it might be. That's the candidate for POLST. That's the target. So it's a subsection. But as you can imagine, we've been talking about dementia today, we've been talking about Alzheimer's, that there could be a really important role that POLST could play. So let me get into that a little bit more. In states, generally they indicate what color the POLST form is. It's a piece of paper. It also includes a discussion, but the POLST form itself is a piece of paper, and states say what color that paper should be. So they do it in different colors so people in a crisis can easily find it. POLST doesn't work in one organization or with just one person. POLST is a community effort. You have to have the whole community behind switching to POLST, or it's not going to work as well. So it's a medical order that indicates a patient's wishes regarding a small set of treatments. And so these are things that could come up in a crisis. And one of the beauties of POLST is that it's set up to transfer across settings with the patient. So what do I mean by that? When a POLST form is completed, that POLST form is supposed to stay with the patient. So if we're talking about somebody who's in a nursing home and then they're going to go to the ER, that POLST form goes with the patient to the ER. And that medical order should be honored by the ambulance service that picks up the patient at the nursing home and by the people in the emergency room. And then if there's an inpatient hospitalization, that form, that medical order follows the person. And so that is one of the beauties of this paradigm, is that the possibility of consistent care is a lot higher. So if you have a patient who you would not be surprised if they died within the next year, then that patient is considered POLST appropriate, or in Iowa, IPOST appropriate. This is what the form looks like. It's actually a salmon colored here in Iowa, but this shows up better for the PowerPoint. So I just want to make sure you know what it looks like. It's posted on the Iowa Department of Public Health's website. You can download them yourself. You can look at it. There's a whole lot of background information about how to use iPost in Iowa, much more in-depth than I can tell you today. And then there are a lot of resources available also for practitioners to consult as you're trying to get your facility post ready or maintain and enhance how you handle post. So the first question on the top of the post form is about CPR, and you can kind of see it there under A, cardiopulmonary resuscitation, and then it gives different kinds of situations. But this medical order only is invoked if a person is found with no pulse and not breathing. And then you can see the rest of these, but decisions that are communicated on the post form. And that's why this can be so important for somebody with dementia, is because that person with dementia is not going to be able to communicate what they want to say if their dementia has progressed to stage 6, stage 7. And so if you have a nursing home resident with dementia going to the ER or the ED, having a post form clarifies what the medical orders are for this person. And in the states, many states have really had very good success with improving the concordance between what people say they want and the kind of care they get at the end of life. So another comparison between post and advanced directives. Advanced directives are for all adults. Everybody should have an advanced directive. Post are for people who are at the end of life, for people who are seriously ill and at high risk of dying in the next year or so. An advanced directive talks about what a person will want in the future in the event that they're not able to communicate. A post talks about current care. After all, it's a medical order, so what's to happen now? Advanced directive, the patient completes that, or the layperson completes the advanced directive, but a post is completed by the healthcare provider, the licensed independent provider. The post results in a medical order. The advanced directive does not result in a medical order. It can influence a medical order, but it doesn't result in one. And then very importantly about the role of the proxy or the surrogate decision maker. In post, the proxy can discuss the post with the provider and can influence the development or the changing of the post, especially if the proxy is the durable power of attorney, right? So if the patient has already assigned this person as the durable power of attorney, then they can serve as a proxy and help get that post form done. A proxy cannot complete an advanced directive. Only the person complete the care that they want in the future. So that's a big important difference between post and advanced directives. And then the last item there, the provider is responsible for having the post available and ready. And with an advanced directive, you can give a copy to your provider, but it's really up to the patient and the surrogate, the family, to know where that advanced directive is. Just a side note, the National Post Paradigm is working on a toolkit that should be available later this spring or maybe early this summer. And the toolkit has some best practices for these different settings. And here in Iowa City, Nicole Peterson with the College of Nursing, Jane Dorman with Iowa City Hospice, and I have been working on the nursing home toolkit for the National Post and also on the hospice toolkit for the National Post. So if you're interested, you've got a lot of resources that help you do iPost well here in Iowa. And if you're listening from another state, there's lots of resources for you as well. But it's not always smooth sailing. Sometimes surrogates will wonder whether to follow the advanced directive of a person with dementia. So now I want to talk about that just a little bit. Let's start with a case, Mrs. Clark. In 2010, she was diagnosed with Alzheimer's. In 2011, she finalized her advanced directive, indicating that when she no longer recognizes her family, she does not want any life-prolonging treatment. That is part of what she included in her advanced directive. And she also appointed her daughter as her durable power of attorney for health care. 2014, she moves to a nursing home. The dementia has progressed, and it was decided with her physician and Mrs. Clark, as well as her daughter, that a do not resuscitate order would be appropriate. Then her dementia continues to progress. In 2017, Mrs. Clark no longer recognizes her family. Her daughter, the durable power of attorney, is visiting 4 times a week and sees her mom seeming to enjoy simple pleasures like petting a cat or eating chocolate pudding. And so the daughter is beginning to consider whether or not she should reverse the DNR, ask for the DNR to be reversed, even though the patient, Mrs. Clark, is not recognizing her family. The daughter is saying, well, she's not as stressed out as she was earlier in the disease. She seems to be more peaceful. She seems to be enjoying herself more. And maybe we should invoke life-prolonging treatments if the situation comes up. There's been a lot in the literature looking at just this issue. When a person makes an advance directive in the early stages of a dementia or early stages of cognitive impairment, when they're still able to discern, does that advance directive still apply in the later stages? And so there, these are some articles. I have a couple other I'd like to share with you just to help flesh out the arguments on both sides a little bit. Much of it centers on the self. What do we consider the self? Is the person who made the advance directive the same person now? Is Mrs. Clark the same person who made the advance directive as the person who's now not able to recognize her family and seemingly enjoying her life? Or is she a different person? Is she a continuation of the person who is no longer? And in most conditions, the health conditions, the self is not affected. But in cognitive impairment and other kinds of dementia, it can be, or what we think of the self can be challenged. And that's where some of these issues come into play. And Hope asks in her 1992 British Medical Journal article, can the earlier self really think itself into the position of the later self? And that harkens back to Mrs. Clark's daughter. She's wondering, well, maybe when my mom made that advance directive, it never occurred to her that she would get to the point where she's less stressed out because she's forgotten she has dementia and she's seeming to enjoy her life. The other piece that can add to this is that we often underestimate just how well we can adjust and adapt to reduced function. There is an article written about the disability paradox and quality of life, where people who were in various stages of disability were interviewed and they reported that they had a good quality of life, in some cases a high quality of life. And the authors talk about when they asked people who weren't disabled to imagine themselves in those conditions and what they think their quality of life would be, the people who weren't disabled did not anticipate such a high quality of life, and Albrook and Dellinger calls that the disability paradox. On the other hand, the disability paradox is focused on physical disabilities. They really didn't include people with cognitive impairment as part of that. But still, it gets people thinking that maybe we aren't that good at anticipating how we would feel later on. Another theory, prospect theory, talks about how the closer somebody comes to death, the more difference they perceive between being quite frail and actually being dead. That if you ask people who are far from being in very poor health about whether or not they would want a lot of interventions to keep them alive if they were in very, very frail health. Many people will say no, they wouldn't want that. And yet, as people get more sick and more frail, they often willingly agree to accept more treatment than they thought they would have earlier. So there's different ways to think about this, and it's a knot that hasn't been fully untangled yet. But the question comes down to, does the earlier competent self, the person who made the advance directive, does that person have priority over the later cognitively impaired self? And that's a rephrasing of the question that I've seen in quite a few different articles and that I've had conversations with people about. But I have to ask myself, is that really a relevant question? Unless we've talked with people about what the self is and how does the self continue, I'm not sure that this is the best question or a most useful question, because when we're inviting people to make advance directives, in most cases, that advance directive is made just precisely for the situation of when a person can't communicate later. And so I do think we need to take that seriously and follow what people have communicated. At issue is, how do we best respect human dignity? And does the experience of the now override the fears or the concerns or the wishes or the values of the person when they were earlier in their dementia and they made the advance directive? And if we think back on the whole purpose of an advance directive, it's that while a person has the capacity to make decisions about their future self, that we encourage them to communicate what it is that they think they would like so that people can try to honor those wishes. This is just another article. I think I'm going to skip over that for right now, and here are some quotes that I pulled out. Those who write an advance directive are expressing their current interests about the treatment they want for the incompetent person they might become. I mean, that's part of the underlying mechanism that's occurring. We're asking people, what do you think you're going to want later? And it is important to respect the wishes of the now competent person. So when you have somebody in your office and they're early in the diagnosis and you're telling them that there is this instrument, an advance directive, that they can appoint the person that they want to make decisions for them and they can indicate some other choices if they'd like, then that person is believing you when you say we're going to do our best to follow that. And we need to be mindful of that. And the last quote on that page from Lemons, the right to self-determination doesn't disappear with a person becoming incompetent. The patient is only limited in exercising that right. The clinical implications. Well, let's go back to the case of Mrs. Clark and her daughter. Patients and families need time, and they need information, and they need emotional support to process what a dementia diagnosis can mean for them. And also that includes a pretty good understanding of the typical unfolding of the disease process, what has happened to other people, what is likely to happen, to the extent that we can say. And then we need to discuss the changes, not just the cognitive and the physical changes, but also some of the emotional changes that can occur. And many people have reported that when the dementia advances far enough, sometimes people's stress level actually goes down because they forget that they are demented. And so that's the situation that came with Mrs. Clark and her daughter. And so if you are part of the clinical team with her daughter and Mrs. Clark, it would have been ideal had that been expressed earlier on when Mrs. Clark was able to weigh in, just to let her know that at some points people get to the point where they forget that they have dementia and they're less stressed, and they are still able to enjoy aspects of life. And how would you like us to honor your wishes at that point? Nobody is talking about hastening death. That's not on the table at all. What we're talking about is that Mrs. Clark had said when she was no longer able to recognize her family, she didn't want life-prolonging treatments. She still wanted good care, she still wanted comfort, but she didn't want life-prolonging treatments. And so the process of advanced care planning should include talking about not just what some of these physical and cognitive changes are likely to be, but also some of the emotional changes, and then the surrogate decision maker is going to be better prepared. We also should talk a little bit about how much leeway that surrogate decision maker has. And then underscoring the importance of the process of advanced care planning. As people, the surrogate and Mrs. Clark, both get used to the idea, they have time to talk with other folks, they have time to witness how other people are functioning, they may get a better idea of what would be in Mrs. Clark's best interest. So understanding Mrs. Clark's personal values, those personal values we can assume will be carried forward even if she can no longer express them. And both Mrs. Clark and her daughter deserve the support that comes from clinicians who have the knowledge and have the experience that many families just don't have. And families can benefit from your knowledge and experience if you also include as part of the discerning process, not the cognitive and physical changes only, but also the emotional changes, and then be willing to revisit these decisions. So thank you for your time and attention. Tune in next month when there's a continuing discussion about decisional capacity and surrogate decision makers, and tune in for the rest of the year when dementia will continue to be discussed. Thanks.